All righty.
Okay.
Cool. All right. Well, again, thank you guys for having me on here. My name is Rod. I am a third-year general surgery resident in Ohio. So my residency program, I'm at Wright State University, and it's common in general surgery residency to do what we call like a 5+2 type of track, where it's 7 years total, and 2 of those years are dedicated research years. So I'm doing my dedicated research years with Cincinnati Children's Hospital Medical Center with the pediatric surgery department. So the objectives here, we're going to run through some cases and talk about presentation, diagnosis, and treatment, which for me is surgical. So we'll talk a little bit about that. We'll talk about general surgery careers, training, and we'll talk about a little bit about why I chose general surgery. And then, of course, we have our Q&A session at the end. So about myself, I grew up in Cleveland, Ohio. My parents, actually like my whole family, except for myself, went to medical school at University of Santo Tomas in Manila. So everybody went there. And then my parents came to America for their residency training. My dad is a pediatrician. My mom is a geriatrician in Cleveland. So I went to University of Cincinnati for my undergraduate. I was a bio major. And then I went to medical school at the same place where I'm doing my general surgery residency here in Dayton, Ohio, Wright State University, Boonshaw School of Medicine. And chose it. Well, you guys will see when you guys are interviewing for medical schools. I think I had like 6 interviews, and I think this was the program that I meshed with the most. It's like you kind of catch a vibe when you go to a place. It's like if you're going to go to medical school for 4 years and, you know, put a lot of time into an institution, you want to make sure that you fit in with the type of people there. And that's kind of how I ended up there. All right. Case number 1. So we have here a 9-year-old male with right lower quadrant abdominal pain. In the general surgery world, we see patients that span from pediatric surgery to trauma surgery to surgical oncology, breast surgery, plastics, you name it. It's a pretty broad list of patients that we get to see. So I figured I'd kick it off with this one. So with that, I'm going to pose it to you guys. If you guys were shadowing with me in real life and this patient shows up, what are some things you want to say to them when you walk into the room? Or ask, I guess.
How are you?
Yeah, definitely start off, especially with kids, you got to break the ice, you know, go in, this kid's in pain. So you want to go in, you want to be pretty friendly. But the basics of like a medical history and a physical exam is kind of where we start. So this kid has pain. So I say, how long you had that pain? You know, how's it feel? How bad is the pain on a scale of 1 to 10? There are all sorts of mnemonics that people use to, you know, memorize all of this. And you guys will get that in medical school. But the gist of it is like, just go in, try and have a conversation with the kid. In pediatric surgery, sometimes that means having a conversation with the parents too. When did this happen? Is this like more than other times when he's had a bellyache? Is this the same? Is he still eating chicken nuggets, or is he pushing it away? What's his status here? And you can kind of get a little bit from the caregiver, whether it's parents, you know, grandparents, whoever their primary caregiver is. And then you want to do a physical exam. Now in general surgery, for us, that means you're mashing on their belly. So a good abdominal exam, which we're taught, look, so you just take a peek at it, listen, you get your stethoscopes out, and you listen to the abdomen. And then you palpate. So we're going to push on it. We're going to find if there are any masses, if there's any spot that hurts more than others. If you push down and then you let go, and then the let go part really hurts, sometimes that's kind of a really scary sign. That's called peritonitis. So let's say we do that to this guy, and he says it's bad, 8 out of 10. And it started about 8 hours ago. It started at my belly button or my umbilicus. It migrated down to my right lower quadrant. When you do the abdominal exam, he's like super tender in the right lower quadrant, meaning the bottom right side of his abdomen. And then when you push on the left side, it doesn't hurt on his left, but actually hurts on his right. All of his vital signs are okay. And he's sitting there and he tells you it even hurt to drive over. Every bump in the road really hurt his belly. So then we got to think, what's on our differential? You got this little kid with belly pain right there, 8 hours ago. I did not know like diddly squat when I was a pre-med, so don't feel bad if you guys don't know. But I mean, what are some thoughts? I mean, what do you guys think could be going on with this kid? Let's say this. Have any of you guys taken anatomy? Or are we too early?
I haven't taken anatomy, but something that kind of stood out to me was just that pain in the abdomen. So then maybe something bacterial infection or something like that. So maybe appendicitis or something else.
Appendicitis, which is actually the most common operation that pediatric surgeons do. And this kid has a classic story for it. So here's a little chart that I always give to like my med students and stuff. When a patient has pain in like a specific area of their abdomen, the first thing is just go to anatomy. What is there? What's in their abdomen there? So you can see in the right lower quadrant, which is this blue part here, appendicitis. The appendix is right there. If they have a hernia, it could be in their groin on the right or the left side. If it is a female, then you have to think, could they have a urinary tract infection? Could it be a gynecological issue? These are all things that you have to consider when they have right lower quadrant pain. In a little boy who has this kind of story in a pediatric hospital, common things being common, I'm going to think it's probably appendicitis, which is like Chloe was saying, or is it Chloe? Sorry. Okay. Like Chloe was saying, it's kind of like a bacterial infection. Your appendix is a tube, and if it gets clogged at the bottom with either hard stool or what we call a fecalith, which is like a poop stone, then bacteria inside the appendix, they keep growing, they can't get out like they usually do, and the appendix gets really angry, and then we got to take it out. All right. So the next thing that we usually do when you think it's appendicitis is we have to get some, we don't have to. You can diagnose appendix clinically, but by the time that I get called as the surgery resident, the emergency department already probably did a couple things. They probably already got blood work, and they probably already got an ultrasound so that they can look at the appendix. Now, here is an image of an appendix on ultrasound where it's kind of dilated. And by that, we mean it's greater than usually 6 or 7 millimeters. And then the walls are kind of thick. Now, the lab work, these numbers, I never memorized them until I was like in my clinical years of medical school, but I can tell you a few things. So if you guys know, you can shout it out. CBC, you know what that stands for?
Complete blood count?
Yes, complete blood count. And in that complete blood count, you get a lot of things. I put my 3 favorite things here. What's a WBC?
White
blood cell?
Yeah, white blood cells. So those are our immune cells. What's HGB? Do you guys know what that is?
Hemoglobin?
Hemoglobin, right? So that's the iron oxygen carrying molecule in our red blood cells. And then platelets. So those are, you guys, I don't know how far deep until, biochem and everything and all that you guys are, but, those are going to help with clotting and things like that. They release different cytokines and things like that. But the white blood cells, so these are the infection type of molecules in our blood. And I'll tell you this, at 17,000 cells per microliter, it's elevated. I can tell you that the hemoglobin is fine for this kid at 13. Platelets are fine. So with an increased white blood cell count, that makes us think, oh, this is probably some sort of infected, well, we should think it's some sort of inflammatory process. In this case, with appendicitis, it's an infectious type of process, right? So your body is trying to fight that, and that's why the white blood cells are up. So what do we do when you have appendicitis? You go in and you cut it out. In 2020, we do a laparoscopic appendectomy, meaning laparoscopic, it's a minimally invasive surgery where we have tiny, tiny little tools. They're like chopsticks with handles and teeth at the end. And then we cut out the appendix. So there is the appendix. And what we do is we make 3 little incisions, one at the belly button, that's where the camera goes, one kind of in the pelvis, kind of in the middle, and then one in the right lower quadrant so we can kind of grab the appendix and move it around and stuff. Here is another picture of some people. I don't think they're doing a laparoscopic appendectomy here, but you can kind of see the tools here and the surgeon. So you can see the patient here. These little plastic things that are going into the patient's skin, those are what we call trocars, and those hold the laparoscopic tools. Those are these little black sticks. Okay, and then the screen in the back, you can see the camera on there. And the quality of these laparoscopic cameras is getting really darn good. So you can see a lot of stuff on there. Okay. And here's a laparoscopic image of someone grabbing the appendix, ready to take it off. So you can see the appendix, which kind of looks like a worm. You can see this lighter pink area in the back. That's going to be the first part of the colon. That's the cecum. And you can kind of follow the appendix leading down into the cecum. Okay. So you cut it out. So let's kind of wrap up this case here, recap it here. Now, this was a kid. If it were an adult, we would actually probably get a CAT scan instead of an ultrasound. Do you guys know why?
Is it because the CAT scan requires radioactive material?
Yeah, it's radiation exposure, right? So we don't like to expose kids to radiation if they don't have to. So we'll do an ultrasound in kids, but really in adults, what happens is by the time I get called, they're going to end up with a CAT scan because that's what the emergency department does in their workup. You know, in their mind, see, I am going to see appendicitis all the time. They don't. So they might think there's something else going on. They're working up something else. So they might get a CAT scan of the abdomen, which is basically what I describe it as, it's the donut of truth. And we're taking a whole bunch of x-rays cross-sectionally, both in kind of like if you cut the patient up into pieces like this, and if you cut them like this, and like this sideways. So it's like making a bunch of slices of bread, and we want to look at those slices of bread, and each one is going to show us different pieces of the anatomy. So you can see here on the right hand side here, you can see the white. This is a one cross-sectional image from a CAT scan where you can see the pelvis. So you see the bones of the pelvis that are lighting up really bright. And then above that, you see the abdomen. So this patient is laying down, their feet is toward you, and their head is away from you, and you're looking inside their abdomen. Okay, so the bones on the bottom here, that's basically their butt. And then at the top here, this is their abdomen, okay? And then you could see here where it says 17 millimeters, that right there is the appendix that the radiologist is trying to show us. The rest of this you could see. A lot of these tubes are bowel. You can see the vessels here as well, the iliac vessels, but I'm not a radiologist, so you'll have to do another virtual shadowing for that. So what did we do for this kid? We did an ultrasound, okay? I don't know how many of you guys are in physics yet. Do you guys know how an ultrasound works?
The sound waves kind of bounce off the denser objects and
Yes.
filter through the less dense ones, right?
Yes. So the ultrasound is filled with crystals. And that's not a weird Gen Z joke about crystals and horoscopes. The crystals vibrate at a specific frequency. That sends sound waves away from that probe towards the object that you're looking at. And you can set that distance that you want, or what we call depth. It will go back and kind of like what Raf was saying, it will hit an object, and based on the density of that object, it will bounce waves back, sound waves back. And then there's a receptor on that probe, and it tells you the density, and that's corresponded to white, black, all sorts of shades of gray. And then from that, you can kind of tell what you're looking at. Okay. All right. Case number 2. How am I doing time? Okay. Case number 2. Let's say you're shadowing me and I'm the trauma resident on call. Now we're at an adult hospital. Okay. And then my pager goes off. I'm like, eating a taco, and you are sitting at the table and you have the pager. You pick it up and I say, read this pager to me. Do you guys know what any of this stuff means? Can you try and decipher it? Give it a shot.
The first one, is it like 24-year-old male?
Yes. This is category 1 trauma. What else do you think? 24-year-old male.
Gunshot wound.
Yes. Right upper extremity gunshot wound. What else do you think this says?
Heart rate 120, BP 100/60.
Mm-hmm. You have your oxygen saturation at 98. And then 2 liters nasal cannula. That's what that means. So if you can see like those tubes that go into people's nose and they're, crank up the tank and they're putting oxygen in their nose. And then a tourniquet is in place, assumably on the right upper extremity. So like his arm, right? All right. So this dude got shot. He's 24 years old. Category 1 trauma means at a level 1 trauma center, or at any trauma center, I guess, the traumas that are coming in, they have a team of emergency medicine physicians, nurses, and all that who are getting the call from the EMTs, and they're going to say what is going on. And then the team at the hospital determines, okay, this is really bad, which is category 1, or this is not so bad, but it's like pretty bad. That's like category 2. In a nutshell, there are actual guidelines for this. You can Google them. But so this one's category 1, meaning stop eating your taco, Rod, and let's run to the trauma bay. This guy, they're giving you some of his vital signs here. His heart rate is 120. I don't know how much you guys know clinical stuff. Is that high? Is that low? Is that normal? Yeah, that's high. I saw Ralph say it's high, right? His blood pressure, is that high? Is that low? Is that normal? You're thinking because it's kind of low, but it could be normal. The 100 could be normal in someone, but the 60 is kind of worrying. So his pressure's kind of low. His heart rate's kind of high. He's breathing okay. He's got a gunshot wound to his arm. So immediately my mind is thinking, this guy is probably bleeding a lot. His heart is trying to make up for all the blood that he's losing by beating faster and pumping more blood to his brain because it's all coming out of his arm. So good thing they put a tourniquet on. All right. So I put the taco down. I grab you by the arm and we run down to the trauma bay. And this really crappy pixelated picture is what the trauma bay is going to look like. Okay. So the patient is going to come in oftentimes on some sort of board, or they're basically on like what these guys have, like that stretcher. The whole team got the page ahead of time when the EMT was on their way. So everyone runs in, throws on their different PPE. This was probably pre-COVID because not everyone's wearing a mask. And we transfer the patient to the bed here. And then all of these people in the blue, once the EMS kind of dropped them off, they get out of the way. All the people in the blue are going to just jump on this guy like crazy, and everyone has a different job. There are nurses who are getting IV access. There's someone at the head who is assessing the airway and all this. So everyone has a different job. But the main thing is when a trauma comes in is what we call the ABCs of trauma. Does anyone happen to know what that is?
Like airway, breathing, and
circulation. Perfect. So airway, breathing, and circulation in that order. So a long time ago, before trauma surgery was invented, there was a physician who was around when he was flying his plane or something when it crashed, and he had to take care of his own family out in the field, and his family got terrible care. And that's when he realized that this should be like a type of medicine, is trauma surgery. And within that is, how do you systematically take care of a patient who is critical, on the brink of dying right in front of you. And what they found is that the first thing that should be assessed is the airway, meaning that pathway from their mouth down to their pharynx, down through their trachea, down to their lungs. Is that okay? Is air able to get down there? Because if that isn't working, if that is damaged somehow by the trauma, interrupted somehow, then the patient's going to die immediately right in front of you. So you have to assess the airway. The fastest way to do that, I usually pat them on the shoulder. I say, hey, my name's Rod. What's your name? And if they can talk back to you, then there's a very high likelihood that their airway is intact. If they can't talk, they're gasping or something, or if this is a gunshot wound to the face, to the mandible, to the jaw, and their airway seems like it's all over the place, their jaw's all floppy, that would be concerning. That's when we would probably have to intubate them. So meaning we put a breathing tube in, okay? B is breathing. So that's listening to their lungs. So some of these people have stethoscopes on. Once this guy gets onto the bed here, they're probably going to throw the stethoscopes on, make sure the guy can breathe on both sides. Because oftentimes with trauma, whether it's a gunshot wound or a, car accident or something, you have the next thing to worry about. If their airway is intact, are they even able to breathe? So air gets down there. Are the lungs okay? All right. And then C is circulation. So C is how's their blood pressure? From a vascular standpoint, are they like this guy where his blood pressure is getting low, his heart rate is high because he's losing all this blood? So for this guy, that's probably about the point in the assessment where we would stop and say, do we have IV access on both sides? It's probably time to give this guy some blood, probably time to give him some fluids, and make sure that his C, circulation, is okay. All right, so that's the primary survey. Oh, I already put it here a little bit. So like I said, A, airway, confirm patency, intubate early if you need to, cervical spine protection. The reason I say that is because if someone got into a car accident, think about their head is like that, or if they fall from a height, if you have damage to your cervical spine, that has implications on their neurological status because your spinal cord's running down through there. So you got to hold their head steady when you're intubating and all that. You don't want to move the neck around. Breathing, like I said, you want to make sure they have bilateral breath sounds. Circulation, you want to evaluate their vital signs, obtain IV access, and resuscitate. And this is the part where hemorrhage control comes into play. So this guy is bleeding out of his arm. He has a tourniquet there, right? So that's the ABCs. There's a couple more. It's really A, B, C, D, E. D, disability, where we calculate a Glasgow Coma scale. That's a neurological assessment. It's a really rough one. It's one that we could do really quickly, especially in the trauma patient. It's not as extensive as a neurological exam. If you guys have had a neurology resident on here, you probably have heard that the neurology exam can get really extensive. We're not doing that in the trauma bay. This patient is dying in front of us. We just want to make sure roughly where they're at. And then environment. So this is the part where I would say medical students play the biggest role. We have to get all of the clothing off. We have to roll the patient on their side and make sure that there aren't any other injuries that we don't know about. So think of situations where a car rolls over. You don't know all the injuries that this person has. You might turn them over and they have a giant laceration on their back. You wouldn't know that unless you cut their shirt off and then rolled them. This patient had a gunshot wound to their arm. Are you going to assume that that's the only gunshot wound? You roll them over and they have another one in their butt, and then you look like an idiot when your attending comes in. So you have to roll the patient over. You have to make sure that they don't have other injuries that you're going to miss. So usually I give my med students a pair of shears, which are like really super strong scissors. And that's the first thing that they do is you just take the shears and cut off the shirt, cut off the pants, look for any other injuries. Now, if the patient is awake and they can move around to some extent, like sure, like, you could take your own pants off, that's fine, but I'm still going to look and make sure that your legs are okay because you'd be surprised what injuries you would miss, okay? All right, so we do that to this guy. Rip off his shirt. Here's the gunshot wound. It's kind of big, actually. I don't know. I got this from Google, so that may or may not be a gunshot wound. But let's say he's got a hole in his arm, okay? He's got a hole in his arm. I don't know how many of you guys have done anatomy or whatever, but there are some important things in the arm, right? Any arteries that you guys can think of that would be concerning in this guy's arm? It's in his upper arm, let's say.
Brachial.
Yeah, the brachial artery, right? So that's a pretty important artery. Now, this guy, let's say his wound looks like this. Immediately in your head, you have to think, is the brachial artery injured? Yes, there are nerves in there too, if you Google it. But my first thought is what's going to kill this guy is bleeding out, right? So let's say that you look at this and you say, oh, cool. All right, well, take off the tourniquet. Let's see how it does. And then there's blood on the floor. And then there's blood on the wall. It splatters all over the place. Arterial bleeding, bright red blood, right at you. Okay, let's put the tourniquet back up. What do you want to do next? What would you guys think? I can't take this down. It's going to bleed everywhere. What do you think? Spoiler alert, I'm a surgeon. So we're going to go to the operating room. And we're going to open this guy's arm up. Okay, so we open up this guy's arm and you see his bicep there, right? His flex arm. All right. And then you can expose his brachial artery. Now there's two branches of the brachial artery, honestly. So if you Google it, the axillary artery comes down and breaks off into what we call the superficial brachial and then a deep brachial. The deep brachial dives deep in there and it's going to supply the muscles that way. The superficial one is a little bit easier to find. You can find it like on the medial side when you roll your biceps like this, and you guys can probably feel your pulse right there if you push your bicep up. This one in the picture isn't injured. This guy's probably getting a fistula or something. But so let's say you open up this guy's and he has a brachial artery injury. Well, you have a lot of different options. It depends on how damaged it is. You could sew it back up, what we call primarily, where you take the two ends. If it's a clean cut, you could take the two ends and sew them back together. You could do a graft where we take a vein and we flip it reverse style because it has valves in it, right? So veins are one way. Arteries, we don't want to put valves in arteries. So you take a vein, you either take the valves out or you flip it backwards, and then you plug it in kind of like a bypass. Or if that's not an option, then you can use what we call PTFE, which is basically like Kevlar, and they have little tubes made out of that. You can plug that in and sew it up. You need your loupes, your microscope glasses to do that because it's really, really small. All right, so we sewed that guy up. Awesome. All right, last case, number 3, 65-year-old Harold. You're in clinic with me. And this guy comes in, he's got blood in his stool. 65-year-old guy with blood in his stool. So same thing. What do you guys want to talk to this guy about?
Have they been eating anything weird?
Yeah. Right. So I asked stuff about his stool. And that's pretty common for a general surgery resident. I'm really comfortable just talking to people about their poop. You could learn a lot. Now, this guy has blood in his stool. So what are you eating? Are you eating beets? Is it really blood? You know what I mean? How much blood? Is it like a lot? Is it like a little? How dark is the blood? Is it black? Or is it bright red? When is the blood? Is it mixed into your poop or is it at the very end when you wipe? You know what I'm saying? You can get really into the weeds with this. I want to know everything I can about this guy's poop. All right, so we talk to him. We do a physical exam. So he's pretty nice. He seems fine. We're at clinic, right? We're just at like the outpatient clinic. He's not in acute distress or anything. He's not dying in front of us. He just noticed over the past 3 months, he's got on and off. Sometimes there's blood in his stool. His belly doesn't hurt. He's not eating anything weird. So we examine him. Heart sounds fine. Lung sounds fine. Abdomen is totally soft. He doesn't have any pain. Vital signs are all okay. We do a rectal exam in the clinic. Now, as a general surgery resident, this is one of the things that we become really comfortable with is how to do a good rectal exam. And there's some things that we're looking for when we do a rectal exam. Right off the bat, I'm testing for the tone, meaning the muscle tone of the sphincters. Is that intact? That has neurological implications. Is there gross blood? Now, obviously, you guys probably think all rectal exams are gross, but gross, we mean like a lot, like visible blood, okay? Can you see it? If you don't, then can you do a Hemoccult test, meaning we smear it on a piece of paper that has chemicals on it and it turns a different color if there's blood in it, like microscopic amounts of blood in it, because really your poop shouldn't have any blood, right? And then the other stuff you're testing, you could do a prostate exam there. That can tell you a lot. You can do, not me because I'm a general surgeon, but it could tell some people a lot. You could test if you feel any masses, rectal masses, anal masses that could be concerning. You can tell some other stuff. I mean, you could tell if there is a hard ball of stool, like a patient who's really constipated, and right when you get into the rectal vault, there's like a rock there. And you're like, oh, well, duh, dude, you got to poop. All right. So then some other stuff I would ask. Family history. Has this guy ever had a colonoscopy? Do you guys know what a colonoscopy is? Okay. Yeah, the camera on a snake, and then you go up the rectum all the way through the colon till you get to the other side, and then you come back out and you're trying to find stuff. The other stuff I was talking about, is this guy constipated? Does he have diarrhea? And then what do you want to do? Okay. So I kind of spoiled it there because I told you about the colonoscopy. So that's what we're going to do next. Okay. And here's just the anatomy of the colon. And then I put on here in your differential, you should think of other things. Okay. So anal, common things that aren't scary. Anal fissures, meaning a tear in the anus. That hurts. That's like when you have too large of a poop and it's too hard and you're constipated and your anus, the skin tears a little bit. Then you get blood there. That's not so scary. It just really sucks. Hemorrhoids, right? So that's when you have basically outpouchings of blood vessels into the anal canal there. Those can bleed. AVMs, or arteriovenous malformations. So basically little weird patches of blood of artery and veins that sometimes they get really dilated, they get interrupted, and then they can pop and then they bleed a little bit. Diverticulitis, those are kind of like when you see these little indentations here in the colon. Sometimes little pieces where it's weak, like where arteries come in, like really, really small arteries come in, that area is weak. And if you're constipated and you're really stressing, then you kind of pop out. It's like a hernia and you're on the inside of your colon. So these little tiny little not holes, but little pockets. It's like all these little pockets. Ralph is not going to be a general surgeon. And then these can bleed. They can pop. You can get food stuck in them. They can get infected. And then obviously the thing in the back of your head that you have to think, in a man this age who isn't keeping up with his colonoscopies like he's supposed to, does this guy have colon cancer, right? Because that's what we have to think of in the back of our head, the scary thing that's going to kill this guy. This guy's not going to die from his hemorrhoids, okay? So screening recommendations for colonoscopy. So whether you, no matter, well, I guess if you're not taking care of kids, but otherwise, if you're whatever kind of doctor you're going to be, colonoscopies are probably going to be some part of your life somehow, I imagine. And the recommendation right now is for patients who are age of 50 years or older, or younger if you have like family history of colon cancer and stuff like that. So basically everybody, when they hit 50, they should get a colonoscopy. All right. And you do the colonoscopy on this guy. On the right, you can see this is basically what the colonoscopy looks like when it's happening. Is this camera on the end there, and it's got these little holes where you could do tools. You can get biopsies. You can put graspers out. In these things, it's like taking a biopsy, taking a little polyp off. You want to get all the way through the colon to the cecum. That's kind of the first part of the colon. So we're going backwards through it. And let's say on this guy, he gets a colonoscopy and you see this giant mass in his sigmoid. Well, you take a bite out of it, send it to pathology. They look at it under a microscope. That's what they see. And they tell you, hey, he's got adenocarcinoma of his sigmoid colon. He has colon cancer. Okay. Well, that sucks. So what do we do next? Well, in surgical oncology, a rule that my program director gave me is when it comes to cancer, you have to name it, stage it, and then treat it. Name it, meaning get the diagnosis. We got that. Next step, you have to stage it. For colon cancer, there are guidelines for that. This guy has to get blood work. We get a CAT scan of his chest, his abdomen, and his pelvis to see if he has any metastases or if the cancer has grown anywhere else besides his colon. We get a CEA, carcinogenic embryonic antigen. Don't quote me on that. You can edit that out. That's probably not right. But it's a tumor marker, okay? We're going to check a tumor marker on this guy. And sometimes that can tell you not necessarily how good or bad the cancer is, but it's a way to track the cancer over time. If it's elevated, it's highly likely that this patient has cancer. And then we can test it post-operatively to see if it's going down, or if it goes up, then does this guy have a recurrence? So it's kind of a tracking type of thing. Depending on where this tumor is, how low it is, if it's in this guy's pelvis, you might have to get an MRI. Okay. And what that's going to do is it's going to tell us a little bit more about the features of the tumor. It's going to tell us if there's possibly lymph node involvement. You can see if lymph nodes are really enlarged there. Let's say this guy, it's in his sigmoid. It's not really in his pelvis. It's like proximal sigmoid. So the final pathology, based on all of our workup, we end up with a T3. I should tell you. Then once we stage it, the terminology is TNM. T for tumor, N for lymph nodes, M for metastases, okay? And then you can look up the guidelines for what each of them mean. But for T, the tumor size is going to tell you it has some bearing on the prognosis. So we have the T stage, which is based on the depth of invasion. So here I have cross-section of the colon. And if this cancer grew down through the muscularis propria, then it's going to be a T3. So, all right. And then we're going to treat it. So for this guy, he's going to go and get a laparoscopic sigmoidectomy. We're going to cut that cancer out, meaning we're going to cut that whole piece of colon out on both ends. And we do that based on the blood supply. So I know you guys haven't taken anatomy, but basically what we do is, for this guy's getting a sigmoidectomy, we're cutting out the sigmoid. But let's say hypothetically that his cancer was on the right side of his colon. He's going to get a right hemicolectomy. That's based on the blood supply. So you can see the right colic artery there. So based on where the tumor is, that's going to guide what kind of resection he's going to end up with. Okay. And then he's get adjuvant chemotherapy. So that means adjuvant, meaning after his surgery, he's going to get chemotherapy. For these patients, it's a combination of drugs, and it really sucks. It's really tough for a lot of patients. But these days, things are getting better in a sense that there are now, I think that we are on the brink of oncology being a lot more like laser focused and personalized to the patient. Sometimes they can undergo genetic testing and things like that. You could send the tumor for specific testing where you can, maybe this guy could qualify for something different than the usual treatment. And that's a whole different road. You got to get an oncologist for the next meeting for that. All right. So let's talk about, those are the three cases. So let's talk about general surgery residency as a whole. I want you to think of all the general surgeons that you know from TV. And here are some of my favorites from Scrubs, from ER, and then from Grey's Anatomy. And basically know that a lot of that is BS. Some of it is true. Obviously some of it is, there's some truth in pieces of it. But for the most part, to me, general surgery, if I had to boil it down to three things to know, I'm going to give them to you right here. One is life and death. I don't think there are a lot of, I think all physicians deal with death, life and death to some extent, but I'm probably biased, but I feel as though the surgeon is closer to death than other specialties. And what I mean by that is, obviously my dad's a pediatrician, and obviously he's had patients who have died before. His patients aren't dying in front of him like they are oftentimes in the general surgery world, like for trauma, or they are not dying over time in front of him, like the patients who have smoldering cancers, who we know the prognosis, we know they're not going to make it very long, and we know there's only so much we can do for them. Or, the vascular patients that we have who have had decades of smoking, they are dying, and there's not much we can do for them other than improving their blood flow here and there. So I think that surgery is really close to death, and it's a double-edged sword, because when you save someone, it's very rewarding. But I think you do have to be comfortable a little bit with the fact that a lot of your patients, you're meeting them because they have a horrible cancer, time, meaning not just, well, let's break that down. Time as in hours. There's a lot of them. I think that as a general surgery resident, we are capped out at 80 hours a week. sometimes that's like 11-hour days, 11, 12-hour days. I get to the hospital at 5 a.m. to see my patients. I might not leave until 7 or 8 some days, depending on how the operating schedule is. And then time, not only in the sense of hours, but in the sense of years. So surgery training, like I told you guys, I'm in a 7-year program. And then I'm going to do a fellowship. That's probably going to be 2 or 3 years. So if you add all this up, like I have friends from medical school who are already attendings, and I'm nowhere close to that. So it's a big commitment for your time. And that has implications on other parts of your life, you know, family life and financially and all that stuff. So these are all things to consider. And then the last part is careers in general surgery, because I think general surgeries, it's there. You can certainly be a general surgeon. I think that my prediction is that the true general surgeon that does all of it, that does everything, is not going to be very common. That's going to be surgeons who are out in the community who have no other options. I think what's becoming more common and what may be better, I think what may be better for patients and what people I think want is to be specialized into something. Be a hernia person, someone who just complicated hernias that nobody can fix. This is the person who can do it. Really complex, bariatrics and things like that. Like people want to go to a specialist these days. I think that patients oftentimes can do better when they have a surgeon who is doing this particular surgery all the time and you get that surgery, as opposed to the general surgeon we see them now. I get trained by some of them and they do a little bit of everything, but I just don't think it's going to be down the road. I don't think it's going to be a thing. And if I'm wrong, then here's this recording and you could tell me I'm wrong in 20 years. All right, why I chose general surgery. Here are 2 reasons. One is music. I used to be a musician before college. I was a drummer. I used to play like jazz. There was something very innate about using my hands to help a patient. There was something very natural to me that I got to like use my hands every day to help someone, save someone's life. And how good you are with your hands, like that's like a thing in surgery. If you're a really meticulous, good surgeon, like that's a thing. And I feel like I kind of relate to that because there are parallels to that in music and your skill level. That being said, I'm a better musician than I am a surgeon, I think. All right, instant gratification. That's the other thing. I think that surgery is unique in that, let's say that first case, the appendicitis, the patient comes in and they're in terrible, terrible pain. This little 9-year-old is screaming, hollering, his pain is so bad. In a few hours, his appendix is out and he's eating ice cream and he's going home. Like hours. He doesn't have to stay the night. It's like that. And he's better. I like that because I have terrible attention span. So I like getting someone better right then and there, sending them home. I don't like tinkering with meds. I don't like my mom, she's a geriatrician, tinkering with meds over the course of a month to make someone's diabetes better. I'm glad that she does it. Bless her heart. I couldn't do that. I can't do that. I need to just fix something right here and then forget about it. All right. So hopefully I'm okay with time, but these are some of my social media handles if you guys want to follow me. And then I'd love to open it up to questions.
Thank you again, Dr. Rod. That was so insightful. We have some presentation related questions, and then like I said, we asked our community, so we'll ask that after.
Please.
Chloe, did you want to go first with your question?
I can't hear Chloe.
Hi, Dr. Rod. Thank you. So when you were talking about the right side and the left side, it's kind of like a small, minute detail. But just for those that weren't aware, when you were talking about the right and left side, is that relative to the patient or is that relative to you as the physician?
Oh, sorry. Okay. When I'm talking about, so if I was ever talking about like patient anatomy and I'm saying right and left, that means it's in relation to the patient. It's like stage right, stage left. So it's the patient's right lower quadrant. When you're looking at them, it's your left-hand side, but it's the patient's right side of his body. But this gets confusing because I'm also doing a PowerPoint presentation. So there are some times where a picture was on the right or left side, and I'm saying this picture on the left. that means like literally you're looking at the screen and it's the picture on the left. So anatomy, if there's ever points in the presentation where I'm talking about anatomy, I'm saying right and left, that's the patient's. Sorry if that's confusing. Sorry about whatever you have to fix in editing.
All right. Oh,
I
Rock,
can't hear
you
you.
muted.
Yeah, you muted.
my bad.
What's up?
So if the patient is unconscious, how do you assess their airway?
Good question. So let me approach this two ways. Sometimes patients come to us in the trauma bay and they're already intubated and unconscious because the EMT, like on the way over, gave them sedation medications to intubate them because they were concerned about the airway in the field. So they did it. In that situation where they're unconscious and their airway, they already have a breathing tube in, when I'm assessing airway and I'm at the head of the bed, I'm basically just taking notes. I'm making sure that the tube is in the right place. I'm noting what length the tube is at because it has a measurement on it. So you can say how many centimeters down it is. I'm looking at, on the tip of it, there's like this special attachment that tells you if they're, it's end-tidal CO2 is what we call it. But basically, if the patient is breathing out carbon dioxide, then it tells us that this is in their lungs, because if it's in their esophagus, then you're not going to get CO2 back. So when I'm assessing an airway of an unconscious patient and they already have a tube, I'm just making sure that the tube is in the right place and all these other things. Now, alternatively, they come to the trauma bay, they are unconscious and they don't have a breathing tube. No assessment. We're going to intubate this patient because another rule that I should have mentioned is with the GCS. So it's a scale of 3 to 15 based on their ability to speak, their ability to open and close their eyes, and then their ability to move around their arms and legs. If you do that calculation in the trauma bay and it's less than 8, then you have to intubate them. So that's the rule. Less than 8, intubate. So if they're unconscious, they're going to have a GCS score of probably 3, which is the lowest one you can get. And then you're going to intubate them. So that's my airway assessment. But obviously, you're going to look at them and everything. Let me also take a step back and say this is for the trauma patient. If you have an emergency medicine or an internal medicine person come in and say, how do they assess a patient? That might be a different story. I don't know. But I'm going to tell you that if I see it, we're going to put a tube in.
Hi, Dr. Rod. Can we ask you to stop sharing your screen?
Oh, yeah. Forgot.
And with that, what are the possible side effects, long-term and short-term, of an appendectomy?
Oh, yeah. So with surgery, instead of side effects, what we say is, what are the complications? So what are the complications of a laparoscopic appendectomy? And they vary. So with every surgery that I do, and I say I do, but I'm the resident, so it's like I'm not really doing it, but you know what I mean? So like I will tell the patient the complications are A, bleeding, because anytime you're cutting open the skin, there's a risk that they're going to bleed. B, infection, meaning we're cutting open the skin. If bacteria gets in here, it could get infected. And then you go into the other things that are specific to that surgery, For a laparoscopic appendectomy, the complications are that either we take the appendix out and then the patient could develop what we call an abscess, meaning that maybe some bacteria got out when we were taking it off, or the appendix burst because it was so swollen. And so there's some like poop in that right lower quadrant there or in the pelvis. Well, sometimes that bacteria can grow and then kind of your body trying to wall it off and fight it. You get an abscess, which is basically a pocket of bacteria, pus, and then like an outer covering. So it's like a little ball of pus and grossness. Okay. So that's one complication. What we do for that is oftentimes, depending on how it is, how big it is, we give them antibiotics and then we send them to interventional radiology, and they put a drain in it, like under a CAT scan, like real time. They watch a needle go into it and they put a little rubber drain in it and let all that pus come out. Bleeding is I know I said it before, but bleeding specifically for an appendectomy, because there's the appendiceal artery, which is a branch of a really big artery, the superior mesenteric artery, that goes right down to the appendix. I guess it's a branch of the ileocecal, and then that's an SMA. But the point is, there's a potential, if you don't seal that artery off, the ileocecal, the appendiceal artery, or the ileocecal, the little branch that is coming to the appendix, then the patient could bleed out a lot. These are pretty rare. Complication rate of a laparoscopic appendectomy is pretty low. It's one of the most common surgeries in America, probably the world. And I know it's the number one like pediatric surgery operation that's done in the world. So the rate of complication is really low, but the only other thing that I would say, which is like super duper rare, is if this appendix, we always send it to pathology, but if this appendix has cancer in it, then you might have to go back in and take more of the colon. So those are the main ones, like off the top of my head.
This is going to be our last presentation question, but since you mentioned that appendectomies are so common, are you aware of any possible social determinants of health that can increase the likelihood of appendicitis, even though it is so common?
That's a good question. I don't know off the top of my head about that. And I'd love to look into that. I don't know. It's just like, what I've found is everybody poops, and sometimes your poop clogs up your appendix. No matter who you are, I feel like we rotate at so many different hospitals. In my program, we rotate at like six or more hospitals around our area. Some of them, like we have our big county hospital, that's like our big trauma hospital, that's like crazy and busy. We have our pediatric hospital, we have our VA, we have a really nice fancy private hospital. Everybody gets appendicitis, no matter what your, like, whatever your situation is, like anyone can get it. Now, then that begs the question, are people who are low SES or people who are minorities, are they getting differential care when they have appendicitis? That I don't know, and I'd love to look into it. If someone finds it, then tweet it at me when you find it. Send me an article. Great question.
So like Chloe said, we're shifting over to questions from our community. The first question, and you mentioned, you've had 6 interviews and you chose your med school. Can you give some advice on how undergrad students like us can stand out to med school admissions committee, or like any advice on what you did that made you stand out?
Sure. That's a great question. And I'll tell you first off that I actually was rejected the first time that I applied to medical school. So I applied, I was super cocky about, like, I come from a family of doctors and I had like pretty average scores. Like I had like a 3.8 GPA and I got like 30 on the MCAT, which is, I don't know what that translates to now, but back then it was like, I was like, oh, I'm going to get into medical school. And then I didn't, because I didn't apply to a lot of places. I kind of like took my application and just did it thinking like, oh, whatever. So what I did in the span between that failed application and the one where I got 6 interviews, I did a bunch of things. I sent my personal statement to, like, I don't even know how many people. It was in the double digits. I sent it to everybody. It was super bad. And by the end of it, I had not just medical people, but like other people. Like I had a family friend who was a speechwriter. She looked at it. It was a totally different speech from a totally different personal statement from when I started. And it was like pretty darn good. I can't take credit for that. That was a team of people who supported me. Second is I drove around my state of Ohio to different medical schools. I said, hey, I applied here. How come I didn't get in? Like, what's up? And just like super thirsty. And they were like, oh, some of them were kind of brushed it off, but some of them gave me some good advice. They were like, oh, well, you're really good academically, but like you don't really have a whole lot of clinical experience. Why don't you volunteer somewhere? So I did. they were like, oh, you do a lot of volunteer work, or you do a lot of extracurriculars. I was in a bunch of clubs and stuff. They're like, oh, but you don't really have a lot of research. So I was like, okay, well, I'll do some research and stuff. So I think everybody's application is gonna have strengths and weaknesses. All of you guys are probably smarter than me. And then some of you guys are volunteering, some of you guys are doing research, some of you guys are in clubs. It's like everyone has different strengths and weaknesses. So you got to figure out what could make me, I always think of it like, what's that saying? It's like a tripod. So you have to have good grades and test scores. You have to have good clinical experience, and you have to have some research. That's like the tripod. And then whatever you sprinkle in, you have to make it personal, So like, I did research in, actually, I did more research like the second time around, but the first time around I did research in like a ecology lab. I was with lizards just because like I thought that was kind of cool. The fact of the matter is that I learned how to like read an article. I learned how to read like a journal article from my PI in that lab. So you just got to take away different things from everything you do. And if there's something that stands out to you, like you think it's really cool, then you have to express that on your application and like convince them like, oh yeah, you're right, that is kind of cool. Whatever that is, you got to speak your truth. Hopefully that answers your question. I don't know, that was kind of vague.
My next question is, can you share your unique experiences as a minority in medicine?
Oh yeah, that's good. I like that. So like I said, like when we first jumped on the call, like Ohio doesn't have, I don't think it has as many Filipinos as you guys have out in California. So for me, like off the top of my head, it's like, I think I know like 3 Filipino doctors that I'm not related to. So for me, it's like, I don't really see a whole lot of that. So I think that the other side is being in, like a red state of Ohio, the patient population is different, right? So I might be like the only Filipino dude that some of these patients have ever met in their life. You know what I'm saying? I'm out in farm town sometimes. So it's weird. I'll say that because you guys probably get this. I feel like this is a Filipino thing, is like the question that's like, what are you? Because I have a Spanish name. So like people speak Spanish to me. I'm in the trauma bay and they're like, we need an interpreter. Do you speak Spanish? And I'm like, Hindi. And that's like, so like I get all the time like that. Maybe you guys get it to a less extent in California because there's more of us out there, but like I feel like I get it very often. Like I think that I grew up around that, coming from, I mean, to be honest, like my parents both being doctors, growing up in the suburbs of Cleveland, I was in like an affluent white neighborhood. So I kind of also stood out there. So feel like I'm numb to that kind of stuff. I laugh it off. Like that's just kind of my personality. But when it comes to medicine, I think that it has a different, it's just got like a different vibe to it, because there's a level of respect, I think, that you want to have as a doctor so that people trust you to like do this patient care. But on top of that, if people just straight up aren't familiar with like what you look like, then sometimes that's a barrier. And it's like, how do you break down that barrier? Well, for me, what I try to do is I try to be like real with them. I feel like I try to relate to people. That's kind of how I try and disarm people, and laugh about stuff. I mean, it's easy and sometimes probably appropriate to get upset about things that patients are saying. But at the end of the day, you have to think, I'm not in this to like, change whatever this person's thoughts are on minorities. I'm here to like take care of them as a patient. And sometimes it's hard to shake that off. And if it is for you, then I think that's understandable and that's fair. But I just kind of laugh it off sometimes. So that's probably not healthy, but that's what I do.
So moving away from our other questions, what inspired you to do TikTok?
Oh, did you guys find me on TikTok yet? So when I got this gig with Cincinnati Children's Hospital, one of the things about my my position is my PI. PI stands for principal investigator, like my boss essentially. He's the social media editor for the Journal of Pediatric Surgery. It's like the highest impact pediatric surgery journal in the world. And he's always looking for new ideas, like to get more reach. Because the idea is, everyone's online these days. How do we get people to click on JPS articles, Journal of Pediatric Surgery articles? And I took this job in July. And so like, the height of the pandemic when everyone's on TikTok. And I was like, dude, I think that like people might like this. And he didn't really understand it. He was like, if you want to do article reviews on here, that's fine. Go ahead. And we could just tweet them out, because like the people who are reading Journal of Pediatric Surgery, they're like on Facebook and Twitter. They're not really on TikTok or Instagram. So he was like, if you make them and then just post them to Twitter, we'll see how it does. They like were very popular, and a lot of people thought they were hilarious, or distracting, or they like really didn't understand what the heck they were watching. But the fact of the matter is, it was driving more clicks to our articles. People are reading the articles, which is the goal, right? To disseminate information. So that's why I got on it. And then I got addicted because like people are funny on there. And I was like, I'm funny sometimes. So I started making videos. And then fast forward, and now today I have like 15,000 followers. So that's kind of how that snowballed.
Thank you for sharing that really amazing story. Our board, we have like 18 people. We shared your TikTok in our group chat. So
nice. Yeah. No, I have fun with it. If you guys ever have an idea, let me know.
Definitely. So we're basically ending. We have one final question, which is our fact tradition that we ask every speaker. What is, or if you could give one piece of advice for all of us, what would it be?
One piece of advice? And you guys are all pre-meds? I'm going to say my piece of advice is have fun in college, because like I remember I was in like these two different worlds. Like I was in a fraternity, so I hung out with these guys who like, were partying all the time. And then I had like my pre-med friends who are always like white knuckling and trying to like ace every test. And I feel like I was Hannah Montanaing like between these two worlds. So like my fraternity brothers, they thought I was like, it was like kind of nerdy that Friday night I'm like, yeah, I'm studying for a biochem test, I can't come. But at the same time, when I do party, it's like we would go hard. And then my pre-med friends thought I was like absolutely insane. They thought I was a crazy person. So I think that what you should do is probably find some sort of balance. Don't do what I did where you're jumping like one world to the other. I think you have to have a good amount of fun in college, because you're only in it once. Once you get to med school, you still have fun and everything, but it's just different. It's not quite, I don't know. It's just not the same. I still had a great time. I made some of my best friends in medical school, but college just is different. So I would say enjoy your time there, because, medicine isn't everything. When you get to the point where I am and you're meeting medical students, like I don't care what your freaking grades are, dude. It's like, can I hang out with you at 3 a.m. when we're on call? That's what I want to know. That's what's important to me. So just enjoy college, have some real life experiences, do well in school, but don't kill yourself over it. Okay.
Thank you for that. Thank you again for making time for us. We will send you the link to the recording, and like I said, we were taking notes, so we have some quiz questions, and I'll just email you just to check over if those are all right with you.
Cool. Love it.
Yes, thank you again.
All right. Thanks, guys. Have a good night.
Thank you.